Hello, everyone. Great to be with you. I'm Doug Beall, interventional radiologist from Oklahoma City. I'm the author of the recent comprehensive guide for vertebral augmentation, and I'd like to talk with you about the vertebral augmentation and the evidence for that. So first of all, there are my disclosures, and to go over some of the objectives, we'll talk about vertebral augmentation as compared with non-surgical management. We'll go over a little bit about the efficacy of vertebroplasty versus kyphoplasty. We'll talk about the number needed to treat, and that's directly related to the mortality of it. And we'll talk about the differences between vertebroplasty and kyphoplasty. Some of the real-world analysis and patient-reported outcomes, the difference between kyphoplasty and implant augmentation, and some of the long-term data. So we hear often about we should try non-surgical management or optimal pain management, whatever phrase you'd like to use for this. But if you do something like examine the data for non-surgical management, it's a real eye-opener. We talk about hard braces versus soft braces and about what's better. And so there's studies by Kim and Bailey that said no brace, hard brace, soft brace for 12 weeks. And we hear about no, you should brace acute fractures or not acute fractures. And then there's bracing versus not bracing for 8 weeks in acute fractures. The answer in all regards to this was no difference in terms of pain. No difference, no difference, no difference. In terms of optimal pain management, there's a meta-analysis by Rezwuska that analyzed the benefit of bracing and analgesics. And to quote from the paper, when analyzing the difference between bracing and analgesics on the patient function, quality of life and pain, they said there's insufficient data to recommend optimal conservative management for osteoporotic vertebral compression fractures. So a lot of questions we get asked about is vertebroplasty versus kyphoplasty. What's okay, what's adequate, what's different? Well, some of the differences really shared and exemplified by the two recent meta-analysis. This one's by Pop and Anastasio, published in 2012, said that kyphoplasty is a little bit better in terms of pain relief and significantly better in terms of quality of life. And both are good about treating patients, getting them up and around and protecting you against adjacent level fractures. And the earlier you treat, the better. This one is one that we did recently in 2018 that said kyphoplasty, unsurprisingly, had significantly better pain reduction than non-surgical management and tended to have better height restoration. So what does height restoration mean? Well, this is the surgical free trial, and this is by our colleague Jan van Meijhegh. And this examined the patient's pain function, quality of life performance in terms of quartile. So the difference between performing at a high quartile versus a low quartile and comparing that performance with the height reduction, and specifically here, the kyphotic angle improvement. The greater the kyphotic angle improvement, the greater the restoration of the normal angulation, the greater the function and or performance in terms of pain function, quality of life. And the difference between being in the bottom quartile of pain function and quality of life was between 3 and 5 degrees. So it's a very small amount of kyphotic angle restoration that can take somebody from the bottom quartile and put them in the top quartile, meaning the top quartile in terms of height restoration and kyphotic angle reduction was directly related to their outcome. These are a collection of mortality papers, some of them involving millions, literally, of patients. The top one was a study we published 2 years ago that had analyzed the entire Medicare claims-based database and 2,077,000 fractures out of 32 million people. And we see similar parallels to most of these. An example of that is the mortality reduction for vertebroplasty is in the range of 25 to 30%. We found 30%. Previous study by Av Edman found 24, 25% mortality reduction for vertebroplasty. And both articles found a 55% reduction in mortality at 1 year. And this mortality reduction wanes a little bit, but still remains statistically significant at 24% for kyphoplasty and 8% for vertebroplasty at 10 years. All of these are statistically significant. This is combined with a meta-analysis recently by Hindi that showed a mortality reduction of 22% overall at 10 years, which is significant and profound. So this is by Ansgar Lang, said that there is a difference between patients that underwent cementation for osteoporotic vertebral compressive fractures and recognized that there may be a benefit in kyphoplasty over vertebroplasty, and also said that kyphoplasty is cost effective. Total costs were lower in these patients than they were for vertebroplasty. And this is not unprecedented, even though it costs more in terms of the initial outlay to perform kyphoplasty. If you measure the effectiveness afterwards, the so-called incremental cost-effective ratios and the quality-adjusted life years are what we use to determine whether or not this has cost-effectiveness enough to perform the procedure, although vertebroplasty and kyphoplasty greatly exceed the value of cost-effectiveness in terms of qualities to perform it. If you follow the cost outwards for 1 to 2 years, kyphoplasty is cheaper than vertebroplasty based on utilization of medical resources, primarily reduction of pain medication. This was found in studies by Ong and Ednan as well, repeated this and found exactly the same thing. These are patient-reported outcomes. This is from the largest registry in the world, the U.S. registry. That was the data was published just 1 year ago. Actually, a few months ago, a calendar year ago. And if this is comparing prompt treatment versus delayed treatment. So in the case one is prompt treatment, 3 imaging appointments and treated promptly with vertebral augmentation as compared with delay for 6 months. And delay for 6 months gives you 16 clinic appointments, 8 imaging appointments, 1 ER visit, et cetera. And that tends to really run the cost up fairly dramatically. So these are 2 studies that determined that vertebroplasty and sham treatment were equivocal. These were small studies that have been subsequently discredited and downgraded to a level 2. Nevertheless, they were impactful at the time, and they resulted in a reduction in the number of patients that were treated from 24 to 14% before and after the publication of those articles, respectively, due to changes in insurance and professional society recommendations, et cetera. And so we know, having studied the mortality, that would have an effect on mortality. Less patients being treated for a condition that is statistically associated with the 8.6 times age-matched controls increased risk of mortality. It should have an effect on mortality. So we analyzed that, and certainly it did. 75,000 people plus were put at risk of mortality, and demonstrably over 6,800 people lost their lives. And we were able to do this kind of in reverse and calculate the number needed to treat to save 1 life at 1 year and 1 life at 5 years. So thank you for those of you who treat people with painful vertebral compression fractures, because the number of patients needed to treat statistically to save 1 life at 1 year is 15. And this is in the range of something like TPA for somebody who comes in with stroke during the golden hour. You'd never think about not giving a clot buster at that time, but and if you analyze this, the NNT for painful vertebral compression fractures at 5 years, it's only 12 patients. So statistically, for every 12 patients you treat, you're saving a life at 5 years. So this is the Evolve trial. This is the largest post-market trial we have, 354 patients as treated on label. And this is treated according to, yes, Medicare criteria in the Meridian region jurisdictions E and F. And we measured 4 primary endpoints and 5 secondary endpoints. And we found statistical significant benefit for all measured primary and secondary endpoints at all time points throughout the entire study, all the way out through to 1 year, which was the study's end. What I also like to point out that our study did significantly better in terms of pain and functional improvements than the other 23 sites combined, probably because we were treating the underlying osteoporosis with anabolic bone agents as well. So the difference between a randomized controlled trial is the difference between, a photograph of the landscape and using your eyes, or a wide angle GoPro lens or something that's able to see. And we don't do a specific trial with specific protocol, inclusion, exclusion criteria done in a specific way with a small group of researchers. We do the registry data collection is done just as it comes. It's agnostic as to the treatment and the investigators. And what we found when we examined the real world practice is that the pain and functional improvements were not only good, they were excellent, with a vast reduction in median pain score of 9 to a 0, and a Roland Morris from a pretty severely debilitated 21 to a 7 at 6 months. So these patients did exceedingly well. And if you roll out all the literature, 51 level 1 and 2 articles from the meta-analyses that I discussed previously, you found a few equivocal trials, and most of these are small and have been discredited, and an overwhelming support in terms of literature for vertebral augmentation, both vertebroplasty, kyphoplasty, and implant augmentation. Speaking of implant augmentation, one of the most recent trials to come out studying the effectiveness of the spine jack compared to, which is an implant, compared to balloon kyphoplasty is the SACOS trial, 15 investigators at 13 sites. And what they measured in terms of pain and function and then quality of life was a secondary endpoint. Also primary was safety and the absence of adjacent level fractures. And this is a relatively small non-inferiority trial of 141 patients. So the results of this were very interesting. So this is 3 superiority claims came out of this trial, which is in all of vertebral augmentation, all 37 years of vertebral augmentation. This is the only 3 superiority claims compared to the predicate that I'm aware of. So predictably, the spine jack, which is great at restoring height, would be better, significantly better restoring height as compared with balloon kyphoplasty. Was also interestingly effective at preventing adjacent level fractures. In the balloon kyphoplasty patient cohort, there was 18 patients with 26 fractures as compared with 12 patients and 8 fractures, for a fracture rate of 12.9% in spine jack as compared with significantly more than that. And the adjacent non-treated fracture rate is about double that at about 25%. So the difference was not only height restoration, fewer adjacent level fractures, but there was also significantly better pain reduction score at 1 and 6 months. And so if we think that the smaller instrumentation gives rise to better pain reduction, we should maybe rethink that, because the spine jack is a larger system than balloon kyphoplasty, and perhaps other things play a role in that, such as sagittal balance, alignment, and the ability to have fewer adjacent level fractures. So in regard to the implants, these percutaneous intervertebral titanium implants, how durable are these? Well, this is a study we published just this last year with David Noriega describing severe type 3 vertebral compression fractures, so burst treated with standalone with spine jack only, and comparing pain, function, and height reduction, not only 1 month afterwards, but following it out to 5.6 years. And we found that this was durable in regard to the pain and functional improvements, but also the height restoration out to in excess of 5 years. So this is long-term and durable. So to bring it all together, essentially non-surgical management for painful vertebral compression fractures has little to no support in the literature. And I'm not an advocate for this, especially when this is associated with a high rate of morbidity and mortality. Kyphoplasty is better than vertebroplasty, significantly better in terms of pain, quality of life, and mortality. It's also better for height restoration. And as we've seen, height restoration has a direct effect on pain, function, quality of life, and is directly related to the success of the patient outcome. The real world outcomes show a high degree of effectiveness for pain and functional improvement, especially in registry data, but also in post-market type data. And we found that implants are better than balloon kyphoplasty for pain reduction, for height restoration, and reducing patients' adjacent level fractures. In regard to the next level of support, implants can be used as standalones. They can be used in terms of Magrill A3.3 fractures, for example, and the long-term outcome can, in terms of pain and functional improvements and height restoration, can be maintained. So when considering these fractures along with unstable neoplastic and traumatic burst fractures, this is a new area that can be expanded upon, and these can be used at least according to initial analysis with good long-term success. So to put it all together, in conclusion, vertebral augmentation is certainly one of the most effective things that we can do. And out of everything that we measured at our facility, this ranks at the very top for pain and functional improvement and patient satisfaction. So implants will allow us to expand the ability to treat these, probably expand to incident level fracture treatment of severe fractures, neoplastic or traumatic fractures, and we'll be able to accomplish more with less degree of invasiveness. And the bottom line is the data is overwhelmingly supportive of vertebral augmentation. My advice to you would be know the data and do more vertebral augmentations where it is appropriate. With that, thank you very much for your attention. I appreciate it. We'll open it up to questions and comments.